Okay, good evening, everyone. I shall start my presentation. Today, my talk will be the tibial fracture after Oxford knee arthroplasty. Can you see my presentation? This is the title page of my PowerPoint. If you cannot see this screen, please send me the chat using the chat. Please inform me. Maybe you can see this title on this title screen. The tibial fracture after Oxford UK. Oh, okay, 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 Brian is welcome. Oh, this is the cause of division after Oxford UK. In the European countries and Western countries, the most frequent cause should be the infection and lateral OA. This is what he reported about 20 years of survival rate after the Oxford UK. Most frequent was infection. This is a Pandit. This is a designer's hospital. The issue 1,000 cases of the Oxford phase 3. The most frequent cause was lateral progression of the OA. This is our study in our data. Is the most frequent cause was the fracture, the tibial fracture, especially tibial fracture. In contrast, the infection and lateral OA is very, very rare. So maybe this is due to some difference of the populations. Maybe the target of the operation is quite different between the Western countries, European and American countries, and Asian countries. So our experience should be very beneficial for you. So why the fracture is occur after Oxford knee arthroplasty? Unlike the other type of the UKA, the Oxford UK has a keel. Maybe this can improve the stability of after the implantation of the tibial tray to the tibia, but in the same time it can cause increase the risk of the tibial fracture. So tibial fracture is reported as a technical error during the operation, including the force hammer, using the heavy hammer and very hard hit to seat the tibial tray on the tibial connective surface. So another is improper pinhole. Some cutting rock has the hole at the medial side of the tibial plateau, like this. So the pinhole adjacent to the cortex of the metaphyseal of the tibia can cause the fracture, even during the operation. During the operation, inserting the pin near the cortex can cause the plaque of the bone here, so they can cause the fracture. Okay, welcome. So another cause should be the posterior cortex damage. This is reported as the most significant cause of the tibial fracture after the UK. So very deep surgical cut. So for example, during the cut of surgical cut, sometimes saw can tend to implant posteriorly that can damage the posterior cortex. And regarding the Oxford knee has the keel throat. Sometimes the keel throat continues to the posterior cortex, and sometimes it can damage the posterior cortex that can cause easily the breakage of the posterior cortex and subsequent tibial fracture. And this is a cutting error. The two medial cut and the two low cut can cause the cross between the cortex and the keel that also can cause the fracture. And cementless. So I don't know you can use the cementless or not. But in Japan, after the introduction of the cementless tibia, 2015, after that, the rate of friction was increased. Even in the doctors, very, very experienced, skilled surgeons. So, extended sagittal cut, the deeper sagittal cut can cause the fracture, and listen and the strength of the posterior cortex. Now, this is the extended sagittal cut, the 0 degrees and 2 degrees and 10 degrees. The most frequent, most weakened bone was the valgus implantation and deeper sagittal cut. So this result show that we should avoid the deeper sagittal cut. In the same time, we should not implant in the valgus. Otherwise, we can experience more cases of the fracture cases. So we never cut the too deep. We never implant the tibia tray in valgus implantation. But it is quite difficult to avoid a deeper cut. Because the posterior side of the intercondylar notch, there is a PCL. Sometimes especially in the very small frame patients, the PCL can push the sagittal saw inferiorly because the space between the intercondylar eminence and the PCL is very narrow, getting narrow. So to the more posterior, the narrow space between the PCL and intercondylar eminence, so the PCL can push the sagittal saw inferiorly. That can cause the deeper sagittal cut. So about this, I recommend to take the CT if you can available. So you can see the deeper cut very clearly just after the operation in the CT scan. I'm White. Hi, welcome. So now this is our experience very, very disappointing. This is have the two cases, two worries. The one is the sagittal valgus implantation of the tibia tray and deep sagittal cuts. So this is just after the about 1 weeks post-operatively. So we can see clearly, we can see the deeper sagittal cut here. In the same time, this is a two media because sagittal cut should be just medial to the tip of medial intercondylar spine. So there are two reasons or three reasons. One is the valgus implantation. The second, the deeper sagittal cut. And third, two media implantation. So if you can see this deeper cut just after the operation, you should take care about the fracture. Sometimes you need to the wet control for the patient. So post-operative operation is very, very important. So especially in the very small patient, as I said before, so PCL can push the sagittal saw inferiorly. So you should take care about it. So currently I insert a small plate after the sagittal cut. Then this small plate can prevent the deeper cut, even if the PCR push the sagittal cut so inferiorly. So I prepare the used saw blade and cut the tip of the saw blade and make a dull sharp surface and insert this user sagittal horizontal saw in between the bone fragment after the horizontal cut. Then make the sagittal cut. This is one idea. So, never use medial pinhole. As you know, there are 3 pinholes for the tibial guide cutting block. If we use this one, like this, I'm sorry, this is not Oxford. Maybe this is the UK. But if we use these holes, the 2 pinholes will come like here. So this hole is very, very close to the cortex, the medial tibial cortex. So we should avoid. I request to the Zimmer Biomet to do not make the hole here on the cutting block. Please feel something to not to use these pins. So please use this hole. Again, in the same time, this pin hole is just on the tibial axis. So after the operation, we can identify the hole for this pin after post-operatively. So we can easily evaluate on the alignment of the tibia using this pinhole. So this pinhole is slightly medium. The bone cut can be the medially sloped, the varus cut. So sometimes we control the alignment of the tibia cut to move this cutting block to slightly medially. But because some patients, in the patient with the tibial burden, proximal tibial burden, even we cut the tibia horizontal cut of the tibia, say perpendicular to the tibia axis, this line should be the valgus in terms of the medial proximal side of the tibia. To avoid this, we should have some way technique to cut the tibia at slightly better angulation. Okay, this is another this very, very disappointed case. This is our experience fracture case. This is X-ray just after the operation. I'm sorry. This tip is very close to the tip, and in the same time, this cutting level is too medium, and cutting level is too lower. Both the sagittal cut and horizontal cut are improper. Eventually, 1 month post-operatively, the patient had a fracture like this. This is the CT scan just after the operation. In this X-ray, the keel has already broken the posterior cortex and anterior cortex. So again, we should cut the tibia just medial to the medial tibial spine, and we should cut not too low. If the cut is a little bit high and the gap is too tight, I recommend to recut the tibia. We don't recommend to cut the tibia again, tibial recut. Instead, please cut the posterior cortex, posterior cartilage, or even the bone from the femur side. Eventually, joint line can increase, level up, but it doesn't matter because we can adjust the gap using the mirror. So after my experience of this patient, I measured the distance from the tip of the keel and the posterior cortex. In the anterior side, there was enough space, but regarding to the posterior side, some patients have the very close. Some patients have the less than 2 millimeters from the posterior keel and the posterior cortex. This result means that even we check the distance from the keyhole and the posterior cortex, it seems enough distance between the keel and the posterior cortex on the cutting surface. But in the lower level, at the tip of the keel level, the distance between the keel and the cortex can be shortened because of the taper shape of the tibial condyle. So this is the pit hole of the post-operative evaluation of the X-ray. This is the X-ray, lateral X-ray. Everyone can understand this placement is proper because we can see the enough distance between the cortex and the keel on the lateral X-ray. But sometimes it can cause the illusion. This is a post-operative X-ray. This distance between the keel and the posterior cortex is very short. The keel is implanted very close. Eventually, after the 3 months later, the patient has to be to our clinic after the implantation of the Oxford knee. After 3 years after the operation, I surprised the patient had a fracture, and the fracture has already healed. So patient experienced a severe pain just after discharge from our hospital, and they keep staying the whole home, and then eventually the pain had gradually disappeared. After 3 months, the patient does not have the pain completely. Sometimes I experience these cases. So if you have the chance to take the X-ray or CT scan just after operation, please have a look. The distance from the keel and the posterior cortex, not cutting surface, but the tip of the keel, the level like this. So because sometimes the plain lateral X-ray can cause the misunderstanding. So we sometimes can cause the misunderstanding or misinterruption of the lateral X-ray because this is a lateral X-ray. It looks very well because there is enough space between the posterior cortex and the keel. But if this tibial tray is implanted in the proper position like this, even in this the figure, the real distance from the keel to the cortex is shorter than the distance on the lateral X-ray because the most posterior point of the tibial medial spine, tibial medial condyle is slightly lateral to the keel position. Again, please see this one. This is the most posterior point. So on the X-ray, we can see here on the X-ray. So this is not to posterior cortex on the extent of the keel position. So cortex on the cortex of the just posterior of the keel is always anterior to the most posterior point of the tibia medial tibial condyle. So this is one point. So another point is if we implant to medial, so this distance can be shorter. Sometimes this keel already broke the posterior cortex at this time. So the next is we should take care to the lateral X-ray, and so the CT scan after the operation, because only the lateral X-ray is not enough. So this is a talk about cementless Oxford. In fact, the fracture after the cemented Oxford is very rare, quite rare, especially for the doctor that has a very good experience of this surgery. So for the skilled surgery, the fracture after the cemented Oxford is very rare. But the now trend is cementless use. So this movement is started from the England in around 2010 or late 2000, but due to the less frequent radiolucence. Because sometimes after the cemented Oxford, radiolucent sometimes occurs. But sometimes this radiolucency can be misunderstood as a loosening. In addition, after the Oxford UKA, unexplained pain is very frequent, not rare. So if the patient has the pain and have the radiolucent, so sometimes the surgeon misunderstands there is a loosening, then they're easy to revise. Because revision of the UKA looks easier than the TKA conversion to the TKA revision. So they believe that cementless use after cementless Oxford, there's a less frequent radiolucency. Then eventually that can decrease the unnecessary revision after the operation due to the radiolucency and the pain. So in the Western countries, especially in the England, the outcome was equivalent or even better than the cemented. And in addition, the fracture was still rare. Sorry, this is a misspell. It is still rare in Western countries, not frequent. But after the interaction to the Asian countries, especially in the Japan, fracture is the more frequent. So very, very many fractures occurred after the cementless interaction. But as I said before, this complication is considered to be due to the technical error. But introduction of the cementless is the usage is limited for the skilled surgeons. So even the skilled surgeons, very experienced surgeons, the fracture is more frequent than cemented one. So we consider this fracture can be caused by the patient factor not the surgeon factor. So what is the patient the factor? Patient side reason. So one possible reason should be the osteoporosis. Many studies have shown that the Asian patients have the very smaller bone density. So bone density the weaker than the Western countries patient. This is the one reason. But virtually no study comparing to the bone density around the knee in the Western countries and Asian countries. And another one is morphology. For the morphology is the tibial bada. Tibial bada and proximal tibial bada is very, very frequent in the Asian countries. This is quite different. The one study shows that the average of the MTPA, the medial slope of the joint line against the tibial axis is approximately 3 degrees in the Western countries. But Asian countries, this angle should be the 5 or 6 degrees in average. So basically, morphology is very, very different between the Asian and the European countries. So I focused on the morphology as a possible fracture risk after the Oxford. So today, this is the end of my talk. The next week, I will continue the talk about our study, because we published the 2 papers about the fracture, about after the Oxford knee, especially cementless Oxford. So it is a very interesting study. So I will explain